So the topic I would like to talk is update for clinical long-term outcome at the TAVR. This is my disclosure. And aortic valve stenosis is a very common acquired valvular heart disease. Elderly patients with other comorbidities are usual situation. Mortality for symptoms of severe AS is up to 50% at 2 years. Around 30 to 40% of severe AS patients in the real world are unsuitable for surgery or denied for surgery. Transcatheter aortic valve replacement or implantation, TAVR or TAVI, was first done in pig model in 1992 by Dr. Henning Anderson. And in clinical practice, Alan Cribre first started first-in-man TAVI in 2002 April as a bailout procedure in a very high sick dying patient. In the worldwide, the TAVI procedure is increasing. For example, in Germany, TAVI procedure is categorized as DRG, and recent years, TAVI procedure is exceeding the surgical case. The gray one is surgical, blue one is TAVI, transapical or transvascular TAVI procedure number. In analysis report, there could be a estimated global TAVI growth number. Currently, annual number is here. In over next 10 years, it will grow over 3 or 4 times. In guideline, European guideline emphasized that the whole team approach. The US guideline emphasized the surgical risk prohibited or very high risk patient. Such as risk is defined as STS prone, frailty, major organ dysfunction, and procedure-specific impediment. Let's look at clinical outcome data. Early data on TAVR showed that in early study period, their predicted mortality was very high, over 10%, and observed mortality dotted red line here. And as study was going on, the lower risk patients were enrolled, and the estimated mortality is lower, and observed mortality lower than that. The black dotted line is usual estimated morbidity mortality in surgical cases. At 2 years, all-cause mortality was in extreme risk group, over 30% at 2 years. In high risk group, 30 to 50, around 30%. And intermediate low risk group showed that around 10% of 2-year mortality. The pivotal trial, one of the pivotal trial was PARTNERA trial, which was the multi-center randomized control trial with severe calcific AS with high or very high risk. Cohort A was defined as the STS score over 10% or surgeon prone over 15% based on existing comorbidity. Cohort B was defined as prone over 50% or serious irreversible condition. TAVI was done as adverse PM value 23 or 26 millimeter. Over 1,000 patients are enrolled in each study group, high risk and inoperable. PARTNERA B cohort was in inoperable patient group, and number was 358, mean STS over 11%. At that study, 1-year mortality was TAVI 30.7, medical group 50.7%, significantly beneficial in TAVI group. Absolute risk reduction was 20%. At 5 years, this beneficial effect of TAVI procedure was maintained. At 5 years, standard red line, TAVI was blue line. The high-risk group, cohort A, showed that the N number was around 700 patients. 2-year mortality was 34% for TAVI, 35% for TAVR. There's no significant difference between groups and no difference in MACE. At 5 years, the trend was similar. TAVI and SAVR was similar probability of mortality. And additionally, there no structural valve deterioration requiring valve replacement surgery in either group. Another pivotal trial was a U.S. core valve investigation using Medtronic core valve. In this study, heart rate improved over 15%, and STS score was 7.4%. 1 year mortality showed TAVI 15% and SAVR 19%. TAVI is superior than SAVR. At 2 years, this superiority of TAVR was maintained as shown here. In other registry or observational, also and randomized trial data of long-term follow-up up to 5 or 6 years showed that the 5-year mortality was 15, 16 was 17%, and 6-year mortality of 60% was reported. TAVI device is evolutionized currently. For Edwards, SAPIEN 3 valve is released, and for core valve, Edwards R retrievable device with low profile is released. The temporal trend in early mortality after TAVR was decreased as shown here with device improvement. Also, stroke event was decreased. How about with the low-risk patients? Recently published the PARTNERA 2A and S3I trial is done for the intermediate risk symptomatic severe AS patients. In PARTNERA 2, transformer primary endpoint of all-cause mortality and disabling stroke was shown here. Red line was surgical AVR, blue line transformer AVR. Transformer AVR is slightly better, showing the endpoint of the mortality and disabling stroke is lower. SAPIEN 3 is the all-cause mortality was shown here. Blue one, SAPIEN 3, red one is the surgery group. So there shows the TAVR was superior than the surgical procedure. As shown before, PARTNERA 2A Cohort A trial, primary endpoint was overall similar between TAVR and surgery, but transfemoral cohort, about 76% of patients, TAVR showed a low rate of death and disabling stroke than surgery. PARTNERA 2 and S3I trial showed that the SAPIEN 3 TAVR compared to surgery improved clinical outcomes and its preferred therapy. There is an unresolved issues. One of them was paravalvular AR. As you know, the moderate to severe AR showed that the adverse prognostic indicator hazard ratio with over 2 or 3. However, recently device revolution and technically improvement was associated with a lower rate of severe moderate AR rate as shown here. Recently released Lotus valve was shown that severe and moderate AR rate was less than 1%. Another problem is permanent pacemaker implantation, reaching up to 30%. However, many studies show that it has no influence on the mortality and clinical impact. As you know, the biosynthetic stenosis regurgitation means that the failure of prosthetic valve is well studied by degenerative, atherosclerotic, or immune process. As expected, top process valve degeneration could be expected, especially tissue crimping within a metallic stent for a low diameter catheter for insertion purpose. On the contrary, there could be a lower systemic inflammation and immune response than surgery. Some studies reported a variable hemodynamic change after TAVR. Effective orifice area and the pressure gradient was reported. That at 5 years, the gradient remained around 10 millimeter mercury, and effective orifice area change was yearly 0.1 square centimeter to 0.06 square centimeter yearly. In clinical trial, they showed that SAVR and TAVR, the pressure gradient change over 5 years was similar in both, around 10 millimeter mercury. This is my conclusion. The future for TAVR, the device evolution is ongoing, and the lack of evidence or critical guideline evidence will be coming soon, even in the low-risk patient, and it is expected that TAVR would be replaced the surgical procedure almost all cases. Thank you.